to the Workforce on Deck podcast. And today we're doing episode 3 of our series with special guest Mickey DeAngelo, and of course, my sidekick, or she calls me her sidekick, Sarah Inman. And we got some interesting topic today. We're continuing our dive into healthcare scheduling. And today we're going to be talking about functional vacancies, or what's also known as the hidden staffing problem. So, hey, I'm going to turn it over to you, to Sarah, to describe exactly what does that mean a little bit as we dive in.
Well, certainly. And yes, you are my sidekick. So thank you for making sure we clarify that publicly for everybody who's listening here. So great to see everybody, or you listen to me, whatever is going on here. We've got our friend Mickey back for episode 3 of our deep dive into workforce management strategy. So, talking about functional vacancies, this is a really interesting topic, and it's one that Mickey and I had talked about whether or not we include in this series at the end of the day. Because when you talk about turnover, when you talk about retention, when you talk about recruitment, really what we are talking about from a functional vacancy perspective is different from those traditional vacancy rates. Essentially, what we want to make sure that we're digging into is talking about all of these different aspects of your workforce management journey and how all of these different components really can kind of flow together in order to create challenges within your scheduling solution, but also just your deeper workforce management. It's like a spider web that all of the different pieces just touch and are interconnected. Mickey, you want to give the people a little bit of background on why we touched on this and decided that we were going to dig in and kind of do a full episode on this versus just, hey, you've got some open positions. What do we do?
Yeah, and I feel let's rename it. I mean, on top of calling it functional vacancy, if organizations or those listening are like, what the heck is that? You can think of it as non-productive time in essence. And I think the reason that we're talking about it now, even before scheduling and to throw the word again, you know, when we think of a workflow, usually we're responding to call offs, FMLA, meetings and trainings, all those different things that shrink your FTE. It usually happens after schedule creation. So, but why are we having this conversation now and not as part of schedule creation or part of the staffing process, which is usually where functionally you're trying to address this? From my perspective, we have to have this conversation first because as an organization, these are all measurable metrics that we should have strategic answers for before we ever create a schedule. And so that's why this conversation is now, and it's why we included it, because there's a lot of methodologies to how we fill these different functional shrinkage opportunities. And I think what I've seen traditionally across healthcare organizations is we throw a lot of spaghetti at a wall and just see what sticks. And what the strategies we're using for one is the same strategy we're using for another without understanding the metrics and how to best pull those different levers to make sure we have the right people in the right place at the right time to care for our patients. And I think really we need to talk about this. What does PTO look like? How do we plan for that? What does that look like? What does it look like from leave of absence perspective? Or even from an absence perspective, like we build float pool schedules a lot of times to cover for it, but are our float pool schedules really built based off of forecasted absences? Sometimes, yeah. Sometimes, maybe not so much so.
Okay. So, for the non healthcare person, I'm going to try to translate this a little bit and see if I get it right. So, when you're saying we're fully staffed on paper, that may not be reality in practice. And the reason may be that, hey, you use some standard out there to say, I need so many people to deliver on this amount of work in a certain department. But what you didn't do is take out all the time that those people are going to be doing things that are not related to delivering in that department, i.e., PTO, i.e., training. So they're not netting that out. So in reality, they're short people at the end of the day.
Yeah, I'll give it. I think that's perfect example, like perfect way to summarize what we said. And quite honestly, this is a simple math problem, right? I'll give an
Right.
example I dealt with at one organization. We talked about this. A lot of times what happens is you incorporate this into your FTE planning. So let's say I have 40 FTEs in a unit and I incorporate, hey, we're going to have another 10% shrinkage. So we're going to hire 44 people. So you usually incorporate that somewhere in your planning process. But does the math? I mean, that's the big question. So the one organization I was thinking of, they average from a PTO perspective, just vacation time around 20%, 2% utilization. The extra quote unquote extra staff they hired for was only 10%. So from a math perspective, before you ever create a schedule, consider leave of absence, meeting train, all this other stuff. You're 12% down out of the gate, not thinking about any other metric. So the math wasn't mathing, right?
And leaders are going into this thinking, "Oh, all my positions are filled. I've got what I need." And that's hence the reason that we're doing this series in the first place, sort of these hidden and insidious areas where it can have a significant impact on your workforce. It can have a significant impact on your budget. If you're having to bring in contingent labor to fill gaps because, oh, yeah, I didn't take into consideration that, all of my population here is going to need to take some PTO. It's part of our benefit plan. This is something that they're going to do. And Mickey, you said it before. Some places are thinking about this when they're building out their schedules, when they're doing their budgeting for the upcoming fiscal year, but a lot of places aren't. And particularly when you're in healthcare and you're thinking about that non-productive time, not directly related to patient care. These things that need to be done, these requirements, the training, the certifications, all of the things that come in as part of being a licensed professional. If we're not planning for that, as you said, you're starting out of the gate behind. And it doesn't matter if on paper you look great that all your positions are filled. So imagine trying to explain that. Vince, you did a great job, by the way. So there's a future in healthcare staffing for you for sure. If you decide you want it, call me after. Imagine having to explain that to a CHRO or to a CFO or a CNO who doesn't understand that piece, who's looking at your schedule going, "Hey, Mickey, you have all your positions filled. Why is your budget continuously over where it needs to be? Why are you putting in requests for agency? Why do you keep monopolizing the float pool?" These are the things that I want leaders thinking about, wrapping their heads around, because it may be a situation where they're bringing this to some of their C-suite for the first time.
Or they're banging
So
their heads against the wall because they don't know why they're like, I don't know why. I just know I don't have enough people to fill shifts. You're right. The numbers aren't there. But again, most of our leaders aren't workforce management experts. They're not paid like you and I to think this all day long, right?
So let's talk about that. So I'm hearing two little different lines of conversation I want to go down real quickly. One, it's a budgetary problem, right? The problem is created before it ever gets to scheduling, as you guys pointed out. So while I may be the person building the scheduling, having to deal with the outcomes, I may already be constrained on how many people I can hire because somebody did the budget wrong because they didn't take all these things into consideration. So there's two pieces to this. I think I'd love to hear us talk about a little bit at how can we educate and train those people upstream to make sure they get it right, because quite frankly, we're going to have to give them the data because we're the ones in the workforce management system. I'm pretending like Sarah, I'm pretending I'm actually doing healthcare scheduling. Okay. I'm putting myself in their shoes. And then second thing is I'd love to run through a hot list of what are all the things they need to be thinking about. Y'all threw a bunch out there, but I would love for us just to kind of go down a poignant list. Here's the things you need to be considering. So maybe we start with the hot list and kind of run through that and go, PTO, what else is it? What are the things that they have to take in consideration as they're starting to build what that labor demand is that they need and get to the FTEs they need?
I see Sarah's like wheels turning, smoke's coming out her ears.
I'm trying to figure out which way I want to answer your question because you kind of gave me two different things to be thinking about, but the
Yes.
list is really the one that I'm spinning my wheels on because as we talked about, there's PTO, there's leaves of absence, but also, and I think I, kind of briefly mentioned these before, there are things, the non-productive time around training for clinical licensed staff that absolutely has to be taken into consideration. And we're talking not just nursing. We've said a couple times through this series that everybody jumps to nursing staffing. but this is physicians and providers. This is respiratory therapy. This is your paramedic team that are staffing your emergency department. So being able to take into consideration and plan for the licensure and training requirements for these types of professionals to upkeep their license. And more what I'm seeing in organizations are, as part of the recruitment efforts to lure people in, they're offering things like paid credentialing time or continuing education units that they're reimbursed for. So if the right hand's not talking to the left and HR and nursing are not coordinating on the fact that not only are we offering this as a benefit, but we're removing people from the bedside and now it's going to create open positions, now what do we do?
I would throw in that this isn't just an HR and leadership discussion, unit leadership discussion. Finance, like finance is usually the one working on this budget, and they have access to the non-productive time. They know what it was like for last year. So they might, what I've seen is they put the budget out like, hey, we're on budget constraints. We're not going to allow as much non-productive time. And so the budget's put out and it is what it is. But to the point I think you're making, there wasn't this more broad discussion of, okay, that's still gonna happen. We still have to let people off. We're still gonna have training. Like, how are we gonna strategically still accommodate that? But Vince, I think we need to jump back to your question too. So there's training, which we were just digging into. There's meeting time, which isn't a big deal, but I've certainly seen where organizations have a standing meeting every Thursday and that's just the meeting time and that's been that guy for 10 years. Well, maybe it's a surge unit and the surgeries now are heavy on Thursdays. Well, have you thought of moving that meeting? Like, so meeting's a small item, but sometimes it can have a big impact on patient care and on staffing. And then leave of absence, attendance, so just regular call-offs and time off. I think those are the major buckets we're speaking of when we're speaking this functional vacancy or non-productive time.
What about turnover? And what I mean by that, right, is it takes time for people to ramp up. They're not an FTE is not an FTE, right? If they're coming on new, depending on what level their skill is set at, if they have to go to training. I know in my past, right, that was definitely something we factored in. I'm not sure if it's appropriate healthcare or not.
Orientation time certainly would be, and I know mature organizations are starting to benchmark those orientation times of because it's not one size fits all. Is this a brand new nurse coming out of nursing school? Are they not learning a new specialty? So, there might be 3 or 4 flavors of how long orientation should be, but I think that's a great call out to throw that bucket in there.
Yeah. So you guys give a pretty good long list, and it sounds like too it's going to vary from department to department. So the suggestion, clear, go department to department, pull all the non-productive time together, right, and figure out how much time you're burning on it, and make sure that that's factored in, right, and understood. That it is going to change, right? I think Sarah, you called that out, right? Depending on which department it is, it's going to have a big impact. Okay, so you've gathered this information and you've got some level of measurement. What do you do with it? How do you help yourself out for the next coming financial year?
You actually pay attention to your data. I had to stop and temper myself the way I wanted to respond there because so many instances I see organizations who have it right in front of them. It's been spelled out that this is what's happening. Here's your delta. This is why you're, seeing an influx in your budget, despite the fact that you appear to be fully staffed. And then they see it and they go, okay, heard and understood. And then they continue to operate the way that they have always operated. And having that data and that information at your fingertips and then choosing to do something about it are two very different things. And unfortunately, we get stuck in this cycle of this is the way we've always done it, or we don't know, we need to continue to research to make sure it's the right thing to do. And it almost becomes a situation of analysis paralysis because it's easier to just continue down the path and be able to say, well, we're fully staffed. Just managers quit having so many meetings, right? Quit letting people go off the floor, quit, letting them go to conferences and do those trainings or whatever the case may be, instead of just acknowledging what's right in front of them and that they have to make a change and do something different from what they've been doing for literal decades leading up to this point without any different results.
I'll take a little bit of a different spin. So, although I wholeheartedly agree, so you're going to incorporate some level of that non-productive time into your core FTE requirements, right? Is it going to fill the whole gap? The likelihood is no. So I think it's taking the rest of that and breaking it down by absence type and talking about what is the percentage. So how many hours do I need through the year to be able to do this? And then talk about how you're going to strategically fill those hours. And to Sarah's point, then continuing to measure. So let's take an example. We say leave of absence, we're going to need 1,500 hours this year. I'm totally making that number up to be able to cover leave of absence. And we think the PRNs can handle that. Like that's gonna be our primary strategy for filling leave of absence. We're gonna leverage our PRN staff. Well, each department's gonna have to look and ask the question, do they have enough PRN staff? Do the PRN staff pick up that many hours on an average basis? Do they need to address PRN policies? Like, and then actually measure against it. Through the year, are we tracking towards we really need 1,500 hours, or are we gonna need now 2,500 hours? Are PRNs actually meeting up to that number? And so that becomes this utilizing your data both historically and in the moment to make sure that you're tracking towards solving for that in the strategic manner that you outlined it would.
Makes sense because you can budget it, but that doesn't mean it's gonna occur perfectly, right? To your point, I mean, you could have multiple people go on LOA at the same time, and all of a sudden you're in trouble because it's hitting all at one time, and you may have a major uptick. So,
And actually, their nurses have babies in clusters. I have seen it time and time again in my
Gosh,
career.
yeah.
I mean, it is one gets pregnant, and all of a sudden you look around and there are 4 pregnant nurses standing around in a unit. And it's just one of those things that no one can plan for. No one can plan for somebody being sick. Nobody can plan for a maternity or paternity leave. But at the end of the day, you have to plan for it because it's going to happen. You may not know the exact person. You may not know exactly when it's going to strike. But to your point about PRNs, Mickey, we're not thinking through fully threaded of all of these different areas where this can have an impact. It also impacts us on whether or not we can open up additional positions from a PRN perspective. If we leverage a float pool throughout the organization, how are we doing that math in determining how many people are actually needed? Do we let anybody who wants to be PRN go PRN, or do we have to have a limit to it? And I've just seen a lot of organizations get themselves twisted up here because in their minds they don't have a crystal ball. So, well, we don't know what's going to happen. So they just assume nothing will happen instead of knowing it will and planning for it, even though they don't happen to know the specifics of when, 3 people are going to fall pregnant at the same time.
I've called out some of the things you need to be looking for. You got to plan for it right. You got to move it upstream to when they're doing the financial budget to try to include it as much as possible. To your point, Mickey, right? They're not going to give it all to you. You're going to map it out and they're going to go, yeah, you get this much extra. So you plan on that. And then you got to manage and execute to it on the real time. And Sarah, you drove home the fact that you need to be looking at the data. So I have a question there. Tools have come a long ways. AI is nuts. It's doubling in functionality every 3 months. Are there AI and other intuitive tools that you're seeing out there that can really help with this or give visibility, or what are you seeing out there?
As the guy that's chief outcomes officer for a tech company, I'll say that's actually one of the things that we're looking at. So we focus on primarily day of staffing, and so we're developing our tools to be able to forecast those absences to give us the visibility into our Friday afternoons where you have the most call offs, and then we can proactively plan on that. Do we need to open up more shifts for that and actually proactively schedule more ahead of time? Can we build flow pool schedules in a more effective manner to meet those call off patterns? So that's what we're looking at on the ANGO side. Sarah, outside of that, I got to be honest, I'm not sure there's a whole lot of technical tools out there to help us in this arena, which is why I came to a tech company that focuses on that, quite honestly.
There's not, frankly. And, anybody out there who's super tech savvy who wants to now take this idea and make their billions of dollars, by all means, please remember where you heard it and remember your friends, the Workforce on Deck podcast. But this is an area that I don't see a lot of technical advances in. And glad to hear that organizations like yours are looking into it and leaning into it, because we hear all of these great things about automation, about AI, everything that we can leverage. And it's a lot. There's a lot of really cool stuff we can do. But this just speaks to, again, that lack of holistic approach. It's not just within the organizations, it's within our industry in general that there's a gap here of specific things that they're looking at. And there's not any one that I know of anyway. And I see a lot of tools, work with a lot of different organizations that can really pinpoint a lot of this. So I don't know. Seems Vince like that may be our next $1 million idea. Step one, find somebody who knows how to build it. Step two, make a gazillion dollars.
Well, we happen to have an AI tool recording this right now. It's already solving the problem and doing the coding for us, just so you know. I'm just saying. So, okay, but I am soon this is going to be, a big area of progression as we continue to move forward to give more real-time managing tools. And Mickey, I love what you guys are doing and where you're headed. I think that's spot on to really help on a day-to-day basis. So let's spin a little bit to more towards the day in action, right? So you've got the budget, you planned it as best you could. Now you're managing it. Are there other things that we can do, advise people to be doing and thinking about to help when you see that issue coming, when all of a sudden there are 4 nurses pregnant and uh-oh, I didn't plan on this much LOA in this short of time. What are some other things that they could or should have been doing ahead of that to help prepare for that? I mean, you kind of have about a 7-8 month runway when you do see 4 women. Well, once 4 women are pregnant, you got a little bit of runway. What are some things that people can be doing besides planning, your PRNs and everything else? What are some other things I can do to try to alleviate the impact it's going to have?
I think you have to start building, and this requires some preemptive planning. You have to build those things into your staffing model. You have to build a leave of absence, maybe not 4. 4 is a lot, right? You can never anticipate when these pregnancy clusters will strike your department. But if you are building an LOA plan into your staffing model, if you are building the fact that if you annually have 12% turnover in your department, you should be building in a 12% turnover ramp time for new employees who need to get started into your staffing plan. If you don't need it because everybody's super happy and stays, which, spoiler alert, never happens, great. Now you are a little more protected from the fact that we have a nursing shortage across the United States anyway, so you're probably going to wind up short a nurse. But it goes into that proactive versus reactive that we've talked about in prior episodes, where you have to be thinking ahead and looking at what historically has happened within your department, within your organization, and applying that to your staffing model. That also helps you go one step further, let you create these predictive float pools. If you know there's 12% turnover vacancy within your organization, you need to make sure within your float pool staffing plan that you have built in at a minimum a 12% vacancy. Then what's our overall call out average? So again, looking at the data you have available, and there are tools that allow you to do this, thankfully. We don't have a tool for everything, but there are tools that give you that really robust data set that you then can take into your planning sessions and apply to the next budget cycle to say, here are the things we know are true. So let's build our staffing plan and policy and structure around what we know is happening within the organization.
I want to build on this whole float pool idea, and we've danced around it quite a few times. And I think really strategically looking at how you develop your float pool is one of the keys to this, right? Because you have float pools aren't the same. Like comparing them, you have your day of float pool that that you're distributing shifts to based on absences and immediate needs. That's different than you might have a tier 2 float pool that you are doing some longer term assignments. They're taking on 6, 9 week assignments. I worked for an organization that we basically built our own internal agency where, we were multi-state. So you could go pick up in South Carolina for 9 months to cover things like that. And I think trying to look at that, because if we look at things like leave of absence, position vacancy, the onboarding, yeah, some of those more strategic, like tier 3 float pool that they're getting long-term assignments, that makes sense. But if you're trying to take your day of nurses and you're trying to fill long-term gaps, that means you have nothing left for the day of gaps that happen. And so I think you have to look at that and try to understand what levers you're gonna pull and develop that float pool strategy. So this is we're speaking that if you're a nurse leader, you can't do this on your own. You need to work with your executive leadership to kind of look at this holistically and say, well, how are we developing this across the board? Although the nurse leader does have some things. Again, do you go to your PRNs? Am I going to get some commitments for PRNs? Maybe it's a season where I know one PRN worker, their kids are in school, they're willing to work more hours, and so I can do those type of things. Or I have a part timer that's willing to work up to full time for a season. So there's some levers that a nurse manager can pull, but a lot of those levers really are more organizational strategy items that have to happen first.
And I think it's a normal reaction to look at a float pool as, oh, this is just a literal group of people who are just available that I can tap into when I need to, instead of having a actual strategy around it. That it's not just people who happen to say they're available and I can call them if I need them. Apply that proactively based on what you know of your organization. How do you make a determination on what minimum requirements are going to be for your float pool staff if you've not applied the data to understand that we need to fill on average X number of open shifts due to vacancy rates, due to turnover, due to pregnancy clusters, whatever the case may be. And again, it's an area where I see a lot of organizations fall short because in their mind, it's, oh, a float pool is an ability to retain nurses who otherwise would have left. So somebody who maybe is taking a full-time position somewhere else, we'll offer them per diem. They can stay here and just be in our float pool. And then maybe they'll pick up a shift every month or two. Okay, that's one approach, but it's not going to actually help you solve your problem. It's just another band-aid in a course of many, many band-aids that we're using to sort of patchwork some type of workforce management strategy together.
And Sarah, I want your opinion on this. In my head right now, especially considering agency rates have come down significantly, there are avenues where agency, at least in my opinion, are the right solution for a leave of absence, for example. I don't want to hire an FTE and all the benefits and all that other stuff that comes with it. It's a that that might be the right tool for that need at that time.
It absolutely is. And I say this in full transparency as somebody who once ran a staffing agency, managed the entire state of Florida for an amazing staffing firm, that we had really, really great people. And there can be some negative connotations around agency. I know there's been a lot of back and forth, particularly when we saw so many nurses leave the bedside during COVID and then become travelers and kind of take advantage of those higher pay rates. But the reality is, if you have somebody who is willing to come in, let's say it's a 12-week maternity leave that they're covering, we're able to orient them. They're acclimated to your culture, to your processes, your policies, and they can make a home, even if it's for a 3-month period within your department. Your organization will be better for that. And you have to do the cost analysis of, if I leave that position unfilled and hope that I can pick up with per diem staff or hope that people grab overtime, then we've got the burnout component that is not a tangible figure that we can actually put a number to, but it's significant. You're paying bonuses and overtime anyway. So in a lot of instances, you wind up kind of upside down from a labor cost perspective as it is. And then you've got the added stress of a nursing leader who, for a 12-week period, is going, how the heck do I fill this? I can't backfill. She's coming back. What do I do? So I'm with you. The agency nurses can't be your default strategy, but they are a tool that you have in your tool belt for something like that. And if you have planned ahead and accordingly that at some point you're going to need some type of leave support over a 12-month cycle, oh, guess what? You can have that type of budget built in because you've prepared for it.
That sounds eerily similar to me to what we deal with as a consulting firm, right? We have to make decisions not only with leaves of absence, but also when we have a minor uptick, right? And I'm sure hospitals get the same thing, right? They have upticks around holidays. They have periods of uptick where it doesn't make sense to go hire more people. It makes more sense to bring people in temporarily. To me, it sounds like they need to have that cost model with the ROI baked in to understand, ready to roll in case something pops up. They know what they need to target for a rate. They know, how long the duration is. They know what the impact is. If somebody challenges on it, they can say, well, it's either shut 4 beds down or we bring someone in. Bad example probably, but that's the reality, right? There's an impact.
Not a bad
So
example. It's a perfect example because you're absolutely right. And Mickey, you spoke to this in a prior episode. You sat in an ER waiting room for hours waiting to be seen, not because they couldn't see you. They didn't have staff to staff the beds. So beds are sitting empty upstairs. That's lost revenue. There are all of those different things that come into play within an organization, Medicare reimbursements, insurance reimbursements, all of those things are not happening and not flowing because you can't staff the beds. So that was a perfect example, Ben. See, Mickey, we're going to turn him into a healthcare expert in no time.
I love how you brought in the whole factor of overtime, extra shifts, fatigue, because throw incentive into there as well, where we were using it. Because I think what we're seeing in the organizations a lot is we're using extra shifts, overtime, incentives, in part to try to address these functional vacancies, and it's leading towards burnout, which is then leading towards position vacancy. And we're creating this cycle that if we just took some time to plan, look at our data, understand, and actually plan out how we're actually going to leverage the staff, that could have been avoidable. Like, I got to be honest, when I'm coaching organizations, I'm trying to avoid overtime and incentive talk at all. Like, can we do this at all without asking our people to work more hours? Outside of like PRN and part-time staff, like, okay, can we bring them up? But my full-time staff, like that to me should be my last resort, not my first, can I offer incentives?
I worked for an organization once who shall remain nameless, who had an employee who worked, gosh, I think it was something like 6 months straight every single day. And those are the things that I'm looking at and I'm thinking about when I see exactly what you're talking about, Mickey, because again, there's the labor cost of, oh, we've thrown incentive at all of these people. But there's also just the human nature instinct of you have these professionals who are in a healing and helping role who, if somebody is coming to them and begging, saying, please, we need help. Can you pick up? Yep. Okay. Yep. I'll get that. Yep. I'll get that extra shift. Yeah. I know that I'm already at 72 hours this week. Like, but you need me. Okay. I'll pick up. Or I've got a kid that's got to go to college and I can't afford it. And if you're offering it, I'm going to take it, even though it's killing my body. Like I'm mentally exhausted. I'm not here. I'm not safe on the road. And this happens every day in healthcare, every day. I'm sure it happens in other industries, but we have a profession and people who are, one, they have our lives in their hands, not to mention what happens once they get on the road and they're exhausted because they've worked 17, 12-hour shifts in a row. So again, there is so much of a non-monetary toll that this takes. And maybe some people don't think about it, but I know I sure do, literal decades later from when I had this experience myself.
all right, Sarah. So based on what you just said, the first thing I'm going to do when I go in the hospital and the nurse is about to poke or prod me, I was asked, when's the last time you had a day off? Just saying, right? It's a little nervous, which I totally get it, right? And it does prevail across multiple industries. You hear about the same thing in manufacturing. You don't see it really in retail but that much because stores close, right? So it's not as big a deal and everything else. You don't have people working 24s and, that kind of stuff. But, that's a little bit scary. But I think the strategy you guys are starting to lay out should help people to prevent that going forward, which is phenomenal. We are getting closer on time, and we want to try to wrap this up pretty quickly. You guys have covered a lot of great points. If you were to surmise it and say, okay, as you're thinking about this as you move forward, and you're trying to address functional vacancies, this hidden staffing problem that's buried inside of most healthcare organizations and others, what are the 3 to 5 points that they absolutely have to take away? We want to give that to everybody.
I'll jump in real quick. So I think to me, this is a simple math and matching game. To the point of the first part of the discussion, understand the math behind it. What are all the non-productive? How many hours? What's the percentage? That type of understand what that is, and then do a simple matching game. So we talked about the buckets of non-productive time, but then there's buckets of, well, how do I actually fill that? And so if 10% or 15% are you're actually up staffing to that, what are you doing with the other 10 to 15, 20%? And actually match up. Okay, for this type, we're going to use PRNs, and for this, we're going to use our float pool. For this, we're going to use actually do a mapping game so you can strategically understand who you're using when. I think we make it way more complicated than it needs to be. That sounds simplistic, and it is more complicated than that, but in some senses, it actually isn't.
I think from my perspective, the first thing is what you measure, you manage, right? So identify what those areas are that you know you need to capture. Again, if it's annual turnover rate, if it's, annual leave of absences, whatever the case may be. But second, that we haven't really touched on too much today is flex your staff. Figure out how you can flex your staff. We've talked about that in previous episodes. Where are there opportunities for you to potentially leverage people within your organization in a way that helps you bridge a gap that may exist today because you weren't thinking proactively ahead of what you needed to do? Is it cross training? Is it upskilling? Is it using programs like a resource nurse, which we've talked about in a previous episode? Are there ways that you can get creative with the staff that you do have while you're hopefully sitting with somebody like myself or Mickey or Vince, our new healthcare strategy expert, to really help you walk through what you can be doing with your next budget cycle and the ones that subsequently will come afterwards to make your life just a little bit easier?
I think if we were to summarize it, let's not just fly by the seat of our pants in trying to address this. Let's actually proactively take a look and understand what's available, what are the impacts, and leverage those tools appropriately.
I think that's fantastic advice. I mean, while it's exciting to live, by the seat of your pants, how fulfilling would it be to know that you're proactive and when that LOA comes upon you, you've got it addressed already. You've already got a plan A and B based on what you just talked about, right? I mean, you're ready. You're ready for anything that pretty much comes at you. So that's fantastic. So awesome job. I think this is great information that healthcare leaders out there, healthcare, forecasting, scheduling people, planners, all those people. I hope you took some great notes. Of course, you can just rewind, listen again. And if in doubt, reach out to us too. And, we can try to jump in and help you and see what we can do for you. All right. So thank you too for joining again. That's number 3 is in the wraps, and stay tuned for number 4 coming up very soon.